I think we're going to go ahead and get started. We have some introductions, and again, thank you all for coming. I wanted to take a couple minutes to thank a few of the people that were just really instrumental in making this happen. The first is Linda Anderson, who's our CEO of the Judy Nicholson Kidney Cancer Foundation, and without her, none of this kind of things would happen. So thank you very much, and on behalf of myself and the entire board of directors. Also want to just give a quick shout out to Tracy Poinier, Joel Stern, and Mark Manning. A lot of the questions, a lot of the discussion, and a lot of just me leaning on them to help put this together has been fantastic. So again, thanks to all of you. The reason we're here though is the amazing panel we have. The panel that was put together, when I saw it, I actually got nervous. These doctors are leaders in the field and in the RCC community, and I attribute the number of people we have on this call directly to this panels. To the doctors, you guys may not be aware, but to a lot of the people on this call, you're rock stars. In the community groups and everything that we all discuss, your names come up a lot, and it's just an honor to at least meet you all virtually and to be able to have this discussion. And your dedication to the battle against kidney cancer and your advocacy for your patients is just truly inspiring and gives us all hope in our battles with this disease. We also have several attendees on this call from the pharmaceutical industry. I would like to just do a quick shout out to Merck for their financial support this year of the Judy Nicholson Kidney Cancer Foundation. Events like this could not happen without the financial support we receive. So thank you very much. A little bit about the Judy Nicholson Foundation. The Judy Nicholson Foundation's mission is to empower and enrich the lives of those affected by kidney cancer. We do this by providing support, education, and community to kidney cancer warriors, both patients, caregivers, families, regardless of geographic or socioeconomic boundaries. That's why we're here. That's why it's so important to us. For those new to the foundation, we hope this seminar is going to be really helpful. I would encourage you also, though, to take a look at our website and join our patient support groups and join our patient support groups, both on Facebook. We have a Real Talk on Renal Cancer podcast. We have monthly caregiver and patient open forums. And this coming October, we actually have a celebration of life dinner in New Orleans that we already have tremendous attendance. I think, Linda, there's still some openings. And with that, on the next day, we are having a kidney cancer education event that's co-sponsored with KCA. But all of these events, you can find more details on the Judy Nicholson website. So I'd just really encourage you to jump on if you haven't and maybe participate in some of those. They've certainly been helpful to me. And I don't need to spend a lot of time on myself, but you guys may wonder who the heck I am. I am honored to be a board member of the Judy Nicholson Foundation and honored to be hosting this event. I personally have been battling kidney cancer since 2020. And I thought COVID was something to worry about in 2020. It turns out some of us had bigger issues. But when I was diagnosed, I immediately jumped on the internet and found out all the very dated and horribly dated statistics, and horrible statistics at that. I'm an engineer by training, and so I started digging deeper and trying to figure out what I was dealing with. And that's when I found the Judy Nicholson Foundation. I found data on the website. I virtually attended a symposium they were sponsored. I found out through the foundation and found through their foundation Facebook groups, support groups. And I wasn't a Facebook guy, but it's been unbelievably helpful to me. I've had to deal with clinical trials. I've gotten kicked out of a clinical trial. I've had to get second opinions and find out how to coordinate between my doctors in Montana and my new doctor, who just happens to be on this panel in Houston. So all of these challenges have been eased by information that I was able to gather and community that I was introduced to through the Judy Nicholson Foundation. So thank you to the foundation and everything that you guys have done for me. I now see Dr. Campbell on the screen. So we have Dr. Msaouel, Dr. Campbell. Jim, do our other panelists able to be on?
Haven't seen any yet. Dr. Msaouel?
Yes, they are.
Okay.
Dr. Manley, yes, everybody's here, and Dr. Hammers is also here.
Awesome, very good.
There's a lot of screens, yes.
So like I said, these guys are the reason we're here. And that's the reason that we have such great attendance. So I just want to do some quick introductions, and I hope I do them justice. The first introduction I'll make is Dr. Pavlos Msaouel. Dr. Msaouel is a physician scientist at MD Anderson Cancer Center, dedicated to kidney cancer research, with a particular emphasis on rare subtypes, such as renal medullary carcinoma. His laboratory identified the serum biomarker currently used to monitor cancer burden in many renal medullary carcinoma patients, as well as many targeted therapies currently used for this disease. His discoveries were accelerated by his introduction of modern data science approaches to research and clinical practice. And he serves as the principal investigator of several completed and ongoing clinical trials for rare and common kidney cancers, including the first such trials designed specifically for renal medullary carcinoma. Next on the list is Dr. Brandon Manley. He is with the Moffitt Cancer Center, has his MD from Temple University, and completed his urological residency at Washington University in St. Louis, and a urologic oncology fellowship at Memorial Sloan Kettering Cancer Center. Clinical practice center on his clinical practice centers on malignant tumors of prostate, kidneys, and testes. I mentioned my doctor is on the panel, so I'd like to introduce Dr. Matt Campbell. Dr. Campbell is associate professor of genitory medical oncology at MD Anderson Cancer Center. He has led and is leading multiple investigator-initiated clinical trials focused in kidney cancer in both clear cell and rare subtypes. His translational research focuses on kidney cancer bone metastases, and Matt has been recognized for physician education and excellence in patient care, and I can attest to that. So proud to have him on the panel. Our final panelist, certainly not last but not least, is Dr. Hans Hammers. And Dr. Hammers is a professional of internal medicine, hematology, and oncology at UT Southwestern. Primary interest is in developing novel, effective immunotherapy for patients with genitory cancers. Has extensive experience in design, development, conduct of early and emerging, as well as pivotal phase 3 immunotherapy trials. Internationally recognized for his expertise in immunotherapy and a key opinion leader in the development of kidney cancer therapies. He's also PI of kidney cancer, primary investigator of kidney cancer initiated clinical trials, as well as DoD supported translational research in drug development. A mouthful. I mean, these guys are so unbelievably highly qualified. And, you know, from the support groups that I'm on, that we interact with, all those accolades are unbelievably fantastic. But what is, I think, even more fantastic is the patient care that these doctors have provided to all of us. So thank you in advance, and thank you guys for taking the time to be part of this event. So event format, and then maybe I can stop talking soon. We'll be spending about the next 50 minutes or so going through some questions that we've seen on our board, on the group forums, and in our community groups. I'll take the first 50 minutes and I'll ask the questions directly to one of the panelists. If any of the other panelists have something further to add, please just interject at your convenience. We're reserving the final 30 minutes for open questions from the audience. Feel free to raise your hand using the Zoom functionality or type in your question in the chat. I've asked Jim to kind of help me monitor both, and Jim will open up your lines to ask the questions when you're called upon. And we'll get to as many as possible. I know there's a lot of questions out there. few quick guidelines when asking questions. Please don't ask specific patient-related questions, as those should be directed to your personal physician. The panelists, don't know the specifics about your case, your history, et cetera. So, please direct those to your personal physician first. And please also understand that all answers given are provided in a general sense, and as every situation is unique, the information provided may not be applicable to all situations. So again, please consult your personal physician or reach out to a doctor for a second opinion. But and which is, by the way, one of the topics we'll cover here. So I guess panelists, are you guys ready to jump in? Let me.
Excited to be here.
All right, thank you. Thank you very much. I'll direct the first question to Dr. Msaouel. Dr. Msaouel, for new RCC patients not staged or staged at 1, 2, or 3, when is the right time to see an oncologist in addition to their urologist?
The answer, as always, is it depends. Okay. Because, for example, let's say this is a so-called stage 2 or 3 renal medullary carcinoma, you need to see a medical oncologist ASAP. And so if it is another subtype, let's say it is, a stage 1 chromophobe kidney cancer, you may never need to see a medical oncologist. So I'm just giving you some examples. So it honestly depends. It helps a lot to have a urologist that you can trust, and they know their job. And we're always happy to help out if there are any questions. If a urologist has any questions about unusual histologies or unusual situations, we're always open and happy to brainstorm. In fact, a few hours ago, that's what we were doing. There was a very unusual case from the further corners of the country, and may never get to see this patient, but we try to help as much as possible, physician to physician. This is not the kind of situation that helps if patients contact. It can actually be more confusing if I start saying things, because it's just not the same transfer of information. But we're always available to physicians for any cases, especially renal medullary carcinoma. In my case, I get 2 to 3 emails per day from physicians around the world to help out with this disease.
Oh, thank you. That actually, like I said, we see a lot of questions on that, and I'm also grateful to be a mentor for the Immerman's Angels program, and the 2 mentees that I have are both early stage and have actually asked me those questions, specifically. Another question I got on that, and we'll stay with you for now, if that's okay, is what about, if you're not yet stage 4, can you kind of give the group an idea of, current protocols for scans, for blood work, that kind of thing, when you're not yet stage 4?
Again, it all depends. For other than, renal medullary carcinoma, where we have a blood biomarker that we follow, CA-125, and we're trying to identify others, any other blood biomarkers are still more exploratory. That we don't use them necessarily in clinic yet as much, although there are some exciting new developments in the most common kidney cancer, clear cell kidney cancer, etc. This is a mistake that, I have seen relatively recently, whereby, oncologists may take the blood tests that were developed for other cancers, like let's say bladder cancer, and they try to use them for kidney cancer. And that ends up creating more noise, and it can cause harm. I had a patient a few weeks ago that the blood marker was showing that things were getting better, and in fact, things were getting worse. So for most kidney cancers, it's not blood tests that we follow to monitor, it's imaging studies. Again, the imaging studies depend on the subtype, and how quickly, how frequently we're going to be doing the imaging depends on the context, the stage, the histology, the type of cancer, etc. So it has to be tailored. to the specific context. The less angry we believe the cancer is, like if it is a stage 1, those are less angry, and it's a histology, a type of kidney cancer that is less likely to come back, the longer the intervals that we do. If we have a high suspicion that the cancer may come back, then we may do shorter interval images, sometimes even 6 weeks after the surgery, rarely, or every 3 months, etc.
So I'll open this question up to all the panelists then, because this was actually, you hit on another question that I had, which is, and I believe maybe some of the blood tests you're talking about are like the Signatera or Natera blood tests. We've seen on the Facebook groups, for example, that a lot of doctors seem to like those tests and use those, for analysis, and others don't seem to put as much weight in those tests. There seems to be a little bit of maybe disagreement in the medical community. Can maybe some of you speak to that?
I can take that. I just yesterday saw a patient with clearly 2 new lesions on the CT scan, and the Signatera test was completely negative. The truth is, for clear cell kidney cancer, it remains a challenge. Blood-based biomarkers are just not very sensitive. Circulating tumor DNA has been more challenging. It's a non-shedding cancer, and I think we need to improve the assays. I think there's good evidence for bladder cancer, for example, where this test or similar tests may be adequate, but in kidney cancer, it's not reliable at this time. I think in general terms, there's enthusiasm for blood-based tests, right? So I think that's something that we all want to have. We want it to work better, and I think Natera, the company, I think is doing a good job in getting physicians to utilize the test, and I think through that we can learn. So we have some very enthusiastic urologists, for example, our practice, who order these tests quite a bit. But they're not yet there that at least I can rely on them. And I think imaging studies supersedes that still at this time.
Perfect. Look, I see some nods of agreement. I'll kind of change the subject a little bit. I'll direct this one at Dr. Manley. For patients who are stage 1 or 2, are there any steps that can be taken to minimize the likelihood of reoccurrence? And then for stage 3 parents, what are your thoughts on adjuvant therapy versus no additional treatment?
Thanks so much. So starting with the stage 1 and 2, it's a very common question, and we get this in all, not just kidney cancer patients, many cancer patients. What can I do? Especially getting ready, maybe we're going to watch it for a little while, or somebody's on active surveillance, right? They have a very small tumor. The only thing that's been tried and true, and a lot's been evaluated, and I certainly hope more comes out, is really things that are good for your heart and lungs tend to be good for your cancer, which is to say overall health is the best thing you can do. Unfortunately, it's not so much that will directly improve your cancer prognosis, but it puts you in a position that you're more apt to receive adequate and tolerate adequate treatment, whatever treatment that may be. So, having those discussions, at the point when especially somebody's getting diagnosed with cancer for the first time is a chance to reevaluate other aspects of their health. So I try and help patients with that, especially patients who are getting surgery. Those things matter. And so, there's no diet that we can say is one better than the other. Obviously, the Mediterranean diet seems to be the one that's, standed the test of time and probably has some value in just overall health, but not directly related to kidney cancer. To answer your second question, stage 3 kidney cancer, when it's having the discussion about adjuvant treatment, there's many factors to consider, right? We have one trial that's showing positive data both in the recurrence and in overall survival, which is certainly encouraging. But, even though we're only using one drug, pembrolizumab in this case, it has risk with it. And every patient comes with their own set of health outside of their kidney cancer, medical issues that could make that drug even more potentially complicated or higher risk. And so, the way that the trial is designed, we have that sort of set of these are the type of tumors we think are eligible for it. But in real world, many of those patients that you're talking across the desk for may not have been eligible for that trial, right? And so you have to consider, well, trying to apply this very sort of regimented qualification scheme to a patient who is not quite as clean, so to speak, gets difficult. And ultimately, the patient has to have the desire, the wishes, and understanding of what the benefits and what the risks are. And that's obviously a conversation between patients. And when it comes to adjuvant treatment, it's also something that needs to take place with the medical oncologist. So, for a urologist who, is familiar with it, I think you could start the conversation there. But certainly a second step is to meet with the medical oncologist, maybe have more in-depth about the treatment regimens and some of the side effect profiles. And a lot of it, I find patients, tend to be on one side of the fence or the other. Very few patients, although it's certainly expected, are sort of undecided when it comes to what they want to do after surgery. And I think part of it is how they recovered from surgery. If everything went well, then a lot of times they're willing to take on more. But, some patients want to get back to their jobs, their families, those kind of things. Those are priorities. And since, surgery can certainly still cure many of the patients in stage 3, it's not unreasonable.
No, that makes a lot of sense. And, I think one of the things that's challenging that I'm sure you guys face every day is, especially when you're first diagnosed and have no education on this, it's hard to even understand what's being said to you. So, I really appreciate the fact that we can have a conversation like this. So maybe somebody who's a little bit newer to the disease can really take some of this and have that conversation with their doctor. So thank you for that. We'll go to Dr. Hammers. Next question is for stage 4 RCC patients. How do RCC oncologists ascertain which first-line treatment to use, since there are currently many choices, thankfully many choices now? And how does this change or does it with clear cell versus papillary, chromophobe, renal medullary, etc.? Oh, you're on mute, Dr. Hammers.
Sorry, I got a call from one of my colleagues. But so it's so I'm a little bit biased, but I will tell you what I think. So first of all, yes, it's true. We have several different choices, and there are certain scenarios where one therapy might be better than the other. I think for patients, for example, let's say clear cell, let's start about that first. For clear cell kidney cancer patients who are in trouble with large disease burden, symptomatic disease, where they should have started, so to say, therapy yesterday, I think the clear choice would be a combination of one of the pills and immunotherapy. Why? Because the response rate is the highest, and it's the best way to get the disease under control right now, where the immediate disease control is paramount. For most patients, though, that's not the case. I think most patients can walk into therapy, and they can walk into what I think is a more effective therapy, at least when you look at the long-term outcome. And that would be dual immune checkpoint inhibition with 2 immunotherapy drugs, where you take essentially 2 breaks off the immune system. So it's my preferred regimen, I think, for most clear cell kidney cancer patients. It also allows you to get a better understanding what happened with immunotherapy, meaning, is there shrinkage in all the tumor lesions that we observed? Is there some heterogeneity? Are some lesions resistant? Shall we go after them with spot welding or surgery, stereotactic radiation? That's something that you don't see when you apply 2 different drugs, a VEGF inhibitor, meaning the pill, and immunotherapy. And it tends to be, although these drugs were never compared, unfortunately, head-to-head, it tends to be, if you look at the long-term outcome at year 5, for example, that the numbers are more favorable for dual immune checkpoint inhibition. So that's something that I prefer. And I would say the recent addition is that even for now good risk or favorable risk patients, we see for the first time a separation in the overall survival curve. So even for patients where we didn't consider this therapy before, it's now clear that this clearly is an option and can be considered for these patients. For the other histologies, I think the standard of care now is the combination of a pill and immunotherapy. So either Carbonivo or Len-Pembro, and I think they're good data sets. The largest data set is actually with Lembertinib and Pembrolizumab, and there were recent changes made to the NCCN guidelines. I think the one exception that I think I'm still struggling with, and many of my colleagues are struggling with, is probably chromophobe. chromophobe seems to be much less responsive to immunotherapy. And if there is not, let's say, a subtype in the chromophobe, let's say a sarcomatoid differentiation pattern, for example, I think most patients will not benefit from immune checkpoint inhibition. And I think that probably is also reflecting the lower response rate to that. And some people think that maybe, for example, lenvatinib, everolimus as a first line is also a good option. So it varies a little bit with the histology. And with that, I would say I give room for my colleagues to chime in and give their opinion.
Yeah, I'm happy to jump in, and I agree with Hans. I mean, I'm a big believer in using the two immune drugs in a good portion of patients with clear cell histology, because I think it leads to a very clean picture if patients are going to be immunosensitive or if they're not. And I think now that we have, 8.5 years of follow-up data from the trial that led to its approval, we now know that about 25% of patients have never had the cancer grow, and the vast majority of them have been off of therapy for a long time, and we believe a good portion of those patients are cured. And I think many patients will elect for trying, even though there carries with it immense risk with immunotherapy, to have that potential to have a long-term response and be off of therapy. There are clearly patients that have very aggressive cancer where it's widely in their liver, bone, or brain at times when they're presenting that have to get an initial benefit. And the challenge with the two immune drugs together is between 20 and 30% will just blow right through it. And that number is much less when we combine a pill with the immunotherapy, where that number is less than 10%. And so in those more extreme cases, I'm often reaching for a lenvatinib pembro or a cabozantinib nivolumab. But in the vast majority, if there is time to try to understand how they respond, that tends to be my selection. I agree with Hans. In the non-clear cell cases, occasionally we still will use two immune drugs together in papillary. Our data at MD Anderson were not as strong with the unclassified as what we would have anticipated based on the data that's been generated with immunotherapy. And I think some of that's because our unclassifieds at places like MD Anderson, Moffitt, and UT Southwestern, we have gone through the extreme analysis to call them unclassified, where I think sometimes in the community setting, that designation is going to be more quickly applied. And so, our unclassified patients often will get an IO-TKI strategy, depending on what we're finding also on a molecular level. And then I'll defer to Pavlos can chime in on his thoughts about some of the rare subtypes, because he really is a world expert at renal medullary and some of the very rare subtypes that we see here.
Yeah, no, thanks. It's funny because literally, I think 2 days ago on formerly Twitter, now called X, there is like a person, I don't know if that was a physician, who said about RMC, hey, what about the dismal prognosis and lack of effective treatment options? And was like, oh, I'm not, not impressed, which is great because it shows how far we've come along since the dark ages that this person still is, thinking that there are no effective treatment options for renal medullary carcinoma. Now there are. But, from the common rare cancers, meaning the ones that, physicians will see at least once in their careers, renal medullary carcinoma was the deadliest one. And it no longer is because of the dedicated efforts made. It still is a very deadly cancer. We still lose too many of them. But now what has happened is that things have flipped. And exactly as Dr. Hammer said, chromophobe, when it's metastatic, and when it is particularly has this sarcomatoid phenotype that Dr. Hammers mentioned, chromophobe sarcomatoid is now one of these very deflating type of situations where we really don't yet have something tailored and effective. And it's a big unmet need that we need to push for more research. Another one is the translocation kidney cancers. Again, we treat those with therapies developed for clear cell kidney cancer. That is the most common one, but they were not developed for this cancer. And, translocation kidney cancer is the most common renal cell carcinoma in children. And so this is another area where we need to do better. The UT Southwestern team is generating exciting data and models for this histology. And so I am very excited to see progress in research and development of new therapies that can help these patients. This is where also one of the things in the chat mentioned, about molecular testing. You will see, especially for the rare subtypes, we do a lot of molecular testing, not just DNA sequencing that looks for tumor mutations, but we have found that RNA sequencing now, which some companies are starting to use, can be very valuable because, you get the RNA that gets turned into RNA that gets turned into proteins, and proteins are the building blocks of the cancer cells. And so by knowing what happens at the RNA level, we get valuable information that, for example, in renal medullary carcinoma, we showed a few weeks ago that can lead to new therapies, but we believe it can help for the other kidney cancer types as well, rare and common.
Excellent. Dr. Manley, you didn't get a chance to weigh in on this, but I have a kind of a similar or slightly divergent question. What about rechallenging immunotherapy in a lot of cases? I mean, we've seen a lot of cases. I've been a recipient of one of the cases where on Pembro, I had significantly higher liver numbers and was subsequently taken off of Pembro. But and we've seen a lot of patients who've had similar outcomes, but has seen a lot of questions say, well, I didn't do good on Pembro, but what about X? What are your thoughts on rechallenging immunotherapy?
Well, first off, I'm not a medical oncologist, so I want everyone to know that. I do a lot of research in that space, so I have a good understanding. But to answer your question, I do want to tie it back to the question you asked me before, and it sort of highlights that fact about being healthy enough to get rechallenged, right? One of the problems with systemic therapies, we have many options, which has been discussed here. But as patients progress through their first line and second line, amazingly, a small percentage of patients only make it to that third line and even smaller fourth line. Most patients only get 1 or 2 lines. Now, for some patients, because they present with such, aggressive disease and metastatic, they don't have that opportunity. So when you're considering the patients that are eligible to be rechallenged, you're usually talking about patients who have less aggressive disease or are really fit patients, right? Who, have, not maybe as many comorbidities as other patients. So I think rechallenging is very reasonable, with the options we have now. I think ideally, for patients who've reached that stage, and again, there's a bias by, I think, the people here and certainly by the faculty here that we're all at major cancer referral centers. But that's definitely the time, if you haven't seeked out those opinions from those major cancer center referrals, to do that, because I think another valid option in that space is a clinical trial. And that's where there's a next generation. It's hard to look back in time, but all of these drugs we talked about were in that phase, in that period of time of development, and patients who were on those trials got access to those drugs and those combinations a lot earlier. And I think there's still many more trials going on that are looking now to do exactly that. After you've gone through the ones we have, the immunotherapies, the targeted therapy, those combinations, what do we do next? And that's definitely debatable. And again, a lot comes on how patients' experience with different drugs. So it's not always the disease. How did they tolerate this drug, whether it was immunotherapy or tyrosine kinase? What has changed since that time? And it gets more challenging. I think the toolbox gets a lot smaller, but clinical trials and an opinion with, a cancer center that runs those trials is definitely something to consider. But a rechallenging is certainly valid, I think, in those cases.
Yeah, if I may chime in, so it's a complicated topic, obviously, and depends on the individual scenario. But personally, let's say if somebody had a serious autoimmune complication, it depends on the grade, depends on the toxicity side effect, and then I tend not to push immunotherapy. First of all, the immunotherapy lasts for a long time. A single dose of pembrolizumab, most people don't realize that, will last months and months and months. The receptor occupancy is impressive. And just because you don't get the next dose, it doesn't mean you're not getting immunotherapy. So it's typically long lasting, and side effects can be long lasting. And sometimes there's no role in pushing it, especially if somebody is doing well. And if you're truly meant to have a major response, you typically still maintain that even if you treat the side effect. The other thing is, rechallenge. If you progress, let's say on a PD-1 inhibitor, let's say you had adjuvant therapy, let's say you progressed on pembrolizumab, there's no role in rechallenging with the same drug or with the same class of drug. It makes more sense to look for different, for different mechanism of action. So, for example, although the chance to respond to, let's say, nivolumab, ipilimumab, the ipilimumab as a CTLA-4 inhibitor, different mechanism of action, is low. It's 10-15%. It's real, though, because the 10-15% is actually the single agent activity of ipilimumab. So if you progress on PD-1, it makes no sense to re-challenge with PD-1. And we have several trials that now clearly show that. CONTACT-03, where patients were re-challenged with a PD-L1 inhibitor. TiNivo-2 will be presented at ESMO. And so trials are showing that it makes no sense to re-challenge with PD-1 after PD-1 progression. You need to think about a different mechanism of action. Think about CTLA-4. Think about in selected patients, high-dose interleukin-2 or interleukin-2 trials, or similar interleukin trials. So I think you need to change the mechanism of action to have a reasonable chance to benefit from it.
That's excellent. Thank you. Dr. Campbell, Dr. Manley, brought up clinical trials. I think when a lot of us hear clinical trials, we're very excited because we want to be on the leading edge of a lot of these things. But when should someone consider going into a trial, and how does one go about doing that? And then kind of the bigger question is, are there any clinical trials out there right now that you or any of the other panelists are really excited about?
Yeah, it's a great question. I think the way that I try to counsel patients is, the reason why the number of treatment options for kidney cancer has continued to expand, really since, it's hard to believe that really less than, if you go back just 20 years in the history of kidney cancer, we had cytokine therapy, which was high-dose interleukin-2 or interferon alpha, that was incredibly beneficial for about 5 to 7% of patients. And that's really all we had. And so, if that's in my, time in going through med school till today, where we've had now this transformation of so many different options that have emerged. All of them emerged are because of clinical trials. And so the more clinical trials that are done that make sense to the clinician and the patients in terms of the schedule of what would be required to participate, what we're exploring, all of these are critical, and we could not do this without the partnership with our patients and caregivers and putting their trust and faith in us that we're giving them good guidance. And so not every clinical trial is a good fit for patients. If I have a patient that comes and sees me that's working full time and lives, multiple hours away and they have to be here once a week, that's probably not going to be a great fit for them. But there may be a study that is a good fit. So, I think we're making some tremendous headway in kidney cancer, exploring some new therapies. And, in recent years, we've had belzutifan emerge. And right now there's a lot of trials that are looking at how belzutifan partners with other drugs and how early it can be given and what that's going to mean. So we're excited to see the results of a lot of that hard work that has been going on. Pavlos has been partnering here on a number of different, what we call cellular therapy trials. And these are where we're engineering T cells, whether these are CAR T cells or natural killer cells to try to target kidney cancer. And there's a lot of iterations of these that are coming out that are being developed right now that I think hold a lot of promise there have been a lot of challenges with these because they're toxic. They require very careful monitoring, and we're having a harder time with these treatments in kidney cancer and other solid cancers as compared to leukemias, lymphomas, and multiple myeloma. And so we feel like we're at the tip of the iceberg in the potential of these studies, and there's a lot to be worked out. But we are really pressing hard to continue this exploration and not abandoning this field because we're running into early challenges. But how can we really take potential of new immune drugs, new drugs that hold potential for kidney cancer, and how can we get them to patients with the idea that, you know, our job here is clearly not done, and we still have a lot of work to be done across the spectrum of kidney cancers.
Thank
And
you,
I think
Dr.
a rule of thumb.
Hey, Dr. Hammers, would you like to comment?
Yeah, just as a good rule of thumb is whenever you think you need to make a change, see somebody for clinical trials, because oftentimes there might be a good idea, right? There are really good drugs available right now that are FDA approved and on the shelf. You can take them anytime. It's just a script. It's very easy to deploy. But you may close the door if you start already belzutifan. You may close the door to combination therapies, or for many other therapies. So when it comes to a decision point, when it comes to changing therapy or initiating the first therapy, my advice would be to always look for clinical trial options, because often these are really good ideas that build on what's already known and what's already available and may give you access to the next generation therapy.
Perfect. Next question, Dr. Msaouel. For stage 4 RCC patients, how often does it take for an immunotherapy or a TKI typically to work? Is 3 months sufficient to make a determination? And along with that, can you explain pseudoprogression?
Yeah. So again, it all depends on the type. I cannot emphasize that enough. And that's why I keep saying it. In the past, people used to look much less. We're much better now at, going and finding the right subtype and realizing that each type is treated differently, but we still can do much better. So I'll keep emphasizing that one of the most important thing that you can do as a patient with kidney cancer is advocate for yourselves and make sure that you have the right diagnosis, meaning the right subtype. And not just, sometimes it can be clear cell kidney cancer, the most common subtype, but it might have nuances. It might have the so-called, we call it sarcomatoid or rhabdoid changes that can also change things. You see what I'm saying? So it's important that we know exactly what we're dealing with, because things are different depending on the type. And what do I mean? For example, taking renal medullary carcinoma again. If you treat renal medullary carcinoma, RMC, with the standard immunotherapies developed for clear cell kidney cancer, those actually feed renal medullary carcinoma. So not only will you not see response, you will see what we call hyperprogression, extreme progression, meaning the cancer will grow faster. Now, if you take clear cell kidney cancer, for example, you may or may not see responses. And sometimes what happens when you're giving immunotherapy, it activates the immune cells, which are, the little soldiers that go to attack the tumor. And as they go to attack the tumor, they make it swell. They make it inflamed, we call it. And as it gets swollen, it looks bigger. That's what pseudoprogression is. Pseudo is the Greek word for false. So it's false progression. It looks like it got bigger, but it didn't. It's just because, it did get bigger, but it didn't get because the cancer grew. It's because the cancer swelled, because the immune cells are going in to do their job. So often you can have the pseudoprogression, and then you check a few months later and you see that the cancer is actually shrinking. So usually for clear cell, let's say kidney cancer, a good timetable for immunotherapy to act is within 3 months. Like if you don't see the kidney cancer respond within 3 months, it probably will not respond. Having said that, I have seen it respond, after 3 months, 4 months, 5 months, etc. Sometimes there is even what we call an initial actual progression, and then there is, the treatment with immunotherapy beyond progression. And sometimes in rare cases, you may see response afterwards. Now, in this, the timing that you mentioned points to something that Dr. Hammers very well alluded to, that immunotherapy takes longer to act. And that goes into the strategy of how we choose the therapies. If we're gonna take, let's say, clear cell kidney cancer, the targeted agents, the agents, the therapies that were developed to target, let's say, clear cell kidney cancer, usually these are the pills, like cabozantinib, Cabometyx, lenvatinib, Lenvima, all of these things. They act much faster. So if you want to see early responses as your first therapy, it's a good idea that you incorporate those in the first therapy, because the pure immunotherapy, if you give only immunotherapy, it will take longer to act. The trade-off is that the targeted agents are far more likely to cause side effects. And sometimes with pure immunotherapy, you may not have any side effects occasionally, but it happens. Whereas if you take the targeted agents, almost certainly you will have some kind of side effect that can impact your quality of life.
What about oligoprogression, where there's pop-ups instead of, and we've seen cases, or we've again in the community talked about cases where the first line treatment's not discarded, but all of a sudden we're using radiation, interventional radiology, et cetera, to treat those type of cases. Can one of you comment on that?
Yeah, I can take that one. So I would say most oncologists have practiced, targeting oligoprogression to extend benefit from therapy. I think for a long time, quite frankly. But one of my colleagues, for example, and I think similar efforts were done at MD Anderson and other institutions, have looked at, if there was or is benefit across the bulk of the disease, and there's just one or two lesions that are breaking out, why not just targeting those specifically with stereotactic radiation or surgery? Stereotactic radiation is much easier, obviously, and then extend the benefit and continue on the therapy that the patient is already on. And I think especially in immunotherapy, they can be actually quite useful. We did a trial that accrued super fast. Why? Because that really reflects, I would say, our clinical practice. And I've had a number of patients who had a mixed response, let's say, to immunotherapy, and you can go after those lesions, actually, in my opinion, with curative intent. Doesn't always work. It may be, you're progressing, they continue to progress, but there's a number of patients who have benefited very much from that approach. Same if you're in trouble, let's say, with the targeted therapy. I have a number of patients, for example, who had progressed on targeted therapy, for example, on a clinical trial with belzutifan that we had now going on for a little while. 2 patients progressed officially on the clinical trial. Merck allowed us to either resect or radiate one of those lesions, and the patients are still on belzutifan, and we could extend the benefit now for a really long period of time, and with it, quality of life. So I think those are really valuable options, and I think that's something to maybe push back on your medical oncologist if they don't think about some of those options and consider them, because that is something where you can extend the benefit, especially if you're doing well on the therapy, especially if you have a good quality of life on the therapy. They can be really, really valuable.
So some of the, when I first got on any treatment, there was data. I read things saying, you can only be on treatment for 1 year, for 2 years. Subsequently, I've been on far longer than that. But are those just rumors? Or those, rules of thumb? What really determines when and how long someone can stay on any course of treatment?
I think it depends on the class of drug also, right? I mean, so obviously, VEGF inhibitors. So first of all, you will always great responders to any kind of therapy. And, all of us had patients respond for years and years and years on the same drug. Immunotherapy obviously the beauty of immunotherapy is that you may get a deep response and you can actually stop therapy altogether. And I would say my practice, I tend to stop immunotherapy after 2 years if somebody's done really, really well. So it really depends. Some patients may continue on immunotherapy because they choose to. So I think it varies quite a bit, but all of us have had long responders to various drugs.
Excellent. Dr. Manley, there's a lot of people in our community, and I think this is really important. And we've talked a lot about this in some of our forum groups that are really intimidated to get second opinions. They don't want to let their primary physician down. They feel that would be some type of affront to their professionalism. What are your views on second opinions? When do you think a patient should get a second opinion? And then subsequently, and I know there's some things going through Congress right now, what about telemedicine versus in-person for second opinions?
Yeah, so I think it's obviously hard when I sit on the side of the table I do, because most people come to me for a second opinion, although certainly some of my patients who I've encouraged to go get other opinions. I think some of it's generational. There's a tradition of, a lot of patients just believe what the doctor says. I think that's becoming less common, but it's still present in some of the populations that we serve. I think absolutely every patient is entitled and should get a second opinion if for whatever reason, just to hear another voice, and reconfirm that the plan that they originally met with their primary doctor is still a good plan. There's a lot of different circumstances when it considers a second opinion. Some of it is the availability to get that second opinion, and which, historically meant traveling usually large distances. And some people, obviously, the finances and logistics come into play. So there's other things to consider than just the pure medicine part. But when you're dealing with cancer in general, which we certainly are here, I think taking all available routes is definitely appropriate. And sometimes pride is the hardest thing to overcome, both for patients, but also for some physicians. I think, again, for the ones here on this panel, we meet with colleagues in academia all the time. So we're used to trading ideas and getting different opinions, and both criticism and, a lot of congratulations. Sometimes outside of academics, that doesn't happen as common, but that's not a patient problem. That's a physician problem. To your point about telehealth, I think that's an amazing opportunity. If there's one good thing COVID did for us, is it forced that issue to come present. And like you said, there's some language going through Congress and stuff that will hopefully broaden that. There's a lot of state considerations when it comes to the availability of telemedicine. So I do tell patients you got to be a little careful on which state you're in or which state you want an opinion. But most of the major cancer centers offer telemedicine. I can't think of one that doesn't. Sometimes, and I guess the one caveat with me being a surgeon is there's, when it comes to surgery, there is some value in seeing a person inpatient. So maybe for a surgical procedure, there's some value in one, you go to the place, you get to see where the surgery happens, make sure you're comfortable with the environment, the people, not just the surgeon, right? His team, her team, whoever it may be, because it's a big care team and you got to be comfortable with all of it. So with surgery, I think sometimes it's worth it, but you can also start with just a televideo and say, well, I like that plan. And, again, in my field, sometimes surgeries aren't as easy to offer at different locations as therapies that are FDA approved. And so sometimes for those of us who specialize in this kind of surgery, there's certain techniques that may only be available at those places. And those are sometimes, not to say that the outside physicians or surgeons aren't aware of them, they just may not be thinking about them. And so there's occasionally patients where I see where we discuss options that were not even previously presented. And again, I don't think they're doing anything wrong, but obviously those patients for those situations are very glad they got that second opinion. When you're dealing with cancer, I say don't hold back, fire every shot you got, because it can be a life or death situation, obviously.
Yeah, and that's what all of us echo when we're having these conversations is it's your life. You need to advocate for yourself and don't be afraid to go get a second opinion. And I know when I first had to go get a second opinion, coming from Billings, Montana, there were no specialists. And my doctor, looked at, we did a first line treatment, and then he went, I'm not sure where I would go next. I would go talk to a specialist. So it made it very easy for me, but I know it's not easy for everyone. I think we can maybe squeeze in one more before we open it up. I'm going to direct this one to Dr. Campbell. because you and I have actually had this conversation. Curious about your opinion, and if you could maybe share with everybody your view of taking breaks from medication to manage the side effects. Are there any statistics that show how that affects the efficacy of the treatment? Is that something you would recommend?
I do. I mean, I think to me, everything that we do, I'm looking at two pillars of importance. We're looking at quantity of life and we're looking at quality of life. And if we are really driving quality of life down significantly, then we're not necessarily doing our patients favors. And a lot of the pill-based therapies that we use in particular do have accumulating side effects that really wear patients down. And I think we can really at times put patients into harm's way, especially if they're getting bad blisters on their feet that are not healing, or they are getting into a scenario where they're spending most of their time each day resting as compared to being active. I mean, we're also putting patients at risk of infection or potentially heart-related issues due to this. And so I think it really requires a partnership with your oncologist of understanding what is the right dose for me, and do I need some built-in breaks to let my body recuperate? And I think especially with a lot of patients today on these therapies for a much longer time frame, because these therapies are working, building in quality of life breaks is important as part of my management skills.
Thank you. It's been wonderful for me. So I love having those conversations and striking that balance, because I think it is extremely important for us as patients to truly stay alive, but also live our life. So it's I think that one hits home. I have a bunch more questions, but I did say that we'd open this up to the audience for the final 30 minutes. Jim, if you can open up the phone lines, let's take some questions from the audience.
Yeah, I would say if anybody wants to ask a question, just to go ahead and unmute themselves and then remute themselves to avoid any background noise.
Don't be shy.
I can jump in really quick because there was a number of questions in the chat that were surrounding bone metastases and the bone modifying drugs that are often provided. This is a big challenge for us because in kidney cancer, the data that supports using bone modifying drugs is a little less convincing in other cancer types. And there's a mixture of data that's emerged where some data has said that using bisphosphonate drugs such as Zometa or denosumab, which is an antibody directed at rank ligand, which is Xgeva, have not shown substantial benefit, certainly not with overall survival. Part of the challenge that we run into are drugs, especially cabozantinib and lenvatinib, do clearly have activity in bone. And we recently published a paper that's accepted for publication where we tested this in our bone modeling, and it does actually improve bone healing when you're on these drugs. And so there is some activity there. What we know is that when you're on one of those pills and you're on a bone modifying drug, both of those work to enhance the chance that you're going to have a breakdown of the jawbone. And in some series, this is as high as 15% of patients to 20% may experience this. And, this is a big problem. And so patients that I think clearly need it, if you're receiving radiation to your spine and you're just getting stereotactic radiation and not any sort of procedure that's going to strengthen that bone, those bones are at very high risk of collapse after radiation, and using a period of time on a bone modifying agent probably is important. But there's a lot of nuance to that question. And I think, this is an important conversation to have with oncologists, and one that we're actively exploring here on several different protocols, trying to better understand this question. This is a big issue for a lot of our patients.
Thank you, Dr. Campbell. Other questions? I'll read
Joel
one.
has his hand.
Oh, go ahead, Linda.
Joel has his hand raised.
Okay, Joel.
First of all, excellent job, panelists and Rich. Learned a lot and really appreciate it. So I'm a big Western medicine fan, but for the first time, I am seeing an acupuncturist, and I'm seeing benefit from it. I'm just interested in your guys as a supplemental to the treatments I'm getting. I'm just curious in your perspective on more holistic treatments, specifically acupuncture, as part of the treatment options.
Yeah, I'm happy to comment on that. So, well, first of all, good to see you, Joe. So I think, so I'm open-minded, to be honest with you. There are many things that we don't fully understand how acupuncture can work. I'm certainly say when it comes to quality of life, well-being, pain control, there are many things that we just don't fully understand where some feedback mechanisms have been worked out for a long time in the more Eastern cultures. When it comes to acupuncture, it can be quite favorable. I have patients who swear on it, and I don't have a problem with them doing it if I don't feel that there would be any disadvantage to it. I mean, I'm more cautious, let's say, when it comes to certain supplements that are not well defined, some snake oil, so to say, that I'm not sure if they may actually hurt, let's say, liver, kidney function, etc. But I would say something like acupuncture, other things, I think it can be tremendously useful for some patients, and I'm fully supportive.
Dr. Hammers, what about drugs? Drugs to help with side effects like THC, marijuana. What's the opinion there?
So I would say that's for me, it's a moving target in that regard. So I think I have a lot of patients who have, let's say, a lot of painful lesions where they swear that THC, let's say the official, well, I mean, there are different products, obviously, but, the CBD oils and medical marijuana and others, where they swear that it improved their quality of life, that they're doing well. Now, I'm more cautious when it comes to, at least in the initial phase of immunotherapy with these drugs, because THC, cannabis are actually immune suppressive. And so I try to avoid it when I try to go for a curative approach with immunotherapy. And I tend to counsel patients not to do that because there's lots of data on the immune suppressive effect of cannabis. So I'm careful there. If you're on targeted therapy, be my guest. Typically, we don't see too many drug-drug interactions there. And so I don't have a problem with that. But if it comes to, let's say, immunotherapy, I counsel my patients to stay more middle of the road, and because that's the one shot at a major outcome.
Thank you. Next question. Glenn Sykes.
Hey, can you hear me?
Yep.
Good. Thanks, everyone. This is really excellent information. I'm so glad I tuned in. My question is for patients that may be further along the treatment curve. We talked about considering clinical trials, which I believe in, and at inflection points in your treatment, that's a good time. At those inflection points, and I'm curious, any of the doctors could opine on this. When there are, I want to say, off-the-shelf drugs, so tested, require just a script, it's done, versus a trial that may be offered. What kinds of things should a patient be thinking about? Saying, I could get the quote unquote easy thing for me from a patient, from a doctor, or a trial. And I know it's a really broad question, and there's lots of different trials, but why would someone go down the path of saying this is readily available to me versus kind of the exploration and potentially participating in a trial? What kinds of thoughts should a patient be considering? Anyone?
I'm happy to jump in, and I would invite Dr. Campbell and others as well. So I'm obviously biased towards clinical trials for the same reason Dr. Campbell and Dr. Msaouel and others, because we want to. I mean, what's on the shelf is not good enough. Period. It can be useful. It is useful. It's they're FDA approved, well validated drugs. The way I think about it is, Glenn, is that, with a clinical trial, you get a shot at something new and it may not work. And many of the times we don't know well if it's going to work or not, whatever. We may quote, 10% chance.
Yeah.
But the way it is, if you have still the big arrow in your quiver, like, let's say, cabozantinib, right? It's not unreasonable to go on the trial. If it doesn't work, just go on cabozantinib afterwards. You have an available drug. And at least you can say you tried something else. And if that doesn't work, you can still go on cabozantinib. Now, it depends on the tumor burden. Is there room for progression? Can you make a major mistake? Things of that nature. So it depends a little bit on that. But if you have, let's say, a reasonable disease burden where the risk of, getting in huge trouble from a little bit of progression after, let's say, a couple of months of a therapy that may not work for you, I think that's reasonable. So it really depends on where are you, what's available. Also, is there excitement around the trial? Let the doctor explain to you why they're excited about it or not, what is maybe some of the emerging data. But obviously I'm biased. But as long as you have a quiver, you can always go back to the off-the-shelf drug if it doesn't work for you. That's how I see it.
Excellent. Thank you, Dr. Albers.
Yeah, I'll add to that. I completely agree with what Dr. Hammer said. When it comes to trials, you want to enroll into trials that are plausible. So they may actually have a shot. And many of the therapies that are now standard of care, we remember when they were trials. So if we do want, if possible, to expose our patients to these new therapies that could make a difference for them. I have patients that, in fact, I get into trouble for this now because I have patients in trials that in theory are not moving forward to become FDA approved, but those patients are being helped. And now I get into trouble because I don't know what to do because the trial will shut down and the patient, may stop taking that therapy. And the thing to consider those is the following. As Dr. Campbell mentioned, with the CAR T cell trials, for example, they're toxic. What does that mean? That means that the more time passes, we're not getting any younger. It becomes harder for patients to be eligible for them because trials do have strict eligibility criteria. So the biggest mistake that people do is to wait to enroll into trials at the end, after they have lost the big guns that Dr. Hammer said. That's why Dr. Hammer said that, hey, if you still have those big tools that are standard of care available, before you use them, it might be a good idea to consider trials now, because later on, first of all, they might not be available, and you may not be eligible any longer.
Right. Can I ask a follow-up question? Because you hit on something, which is sort of, do you feel like the trial offers promise? And certainly, doctors can inform that thinking. But for early phase trials, and I'm talking about phase 1 and phase 2 trials, how is a patient able to grasp that promise to say, yeah, this sounds really exciting and really good, and I want to try my luck at it, which boils down a little bit to luck.
It is very rare that I will offer to a patient a clinical trial that does not have a plausible promise. It does not matter whether it's a phase 1 or phase 2. Phase 1 just means we're trying to find the right dose,
right?
But the mechanism will need to have promise, at least for me, to say, hey, go to that. We don't want to just experiment.
Right.
We want to help patients and enroll in something possible. And that can be a phase 1, that can be a phase 2. In fact, some patients may prefer a phase 2 to a phase 3 because with a phase 3, they may get randomized to the so-called standard of care.
Yeah.
So the phase doesn't matter as much as the plausibility that this might help. And, we might do this molecular analysis and other analysis to see, Maybe your cancer expresses that target. And obviously, you know, when it comes to phase one caveat is sometimes early on in the dose, as they're escalating the doses, you know, the dose might be too low. But usually when we refer patients to phase one, the dose has been escalated to the point that it makes sense that it could help if it is meant to help you.
Yeah, I think that's a great point. The other, you know, the other thing is also, maybe it's worth highlighting a little bit how we actually think about the clinical trials and which ones we actually choose. So for example, if I don't understand the clinical trial, I'm not going to open it. If there's no enthusiasm for a particular target, I'm not going to open it. So first, you know, it's not only, so drug companies come to us with their things and they ask us, do we want to participate? First, I think, like, you know, Dr. Campbell, Dr. Msaouel, they want to be convinced that there is something scientifically that's actually very interesting to it or not. Then we take it actually to our own group for scientific review. And we need to defend it. We put it up there, questions are being asked. So even like the own group needs to be convinced, hey, this is worth putting patients on. Do we have enough patients? Does it make sense? And I think there is actually quite some process in there. We just don't, you know, I would say most sites, especially academic sites, have this more rigorous process where several different people will look at that. And if it doesn't make sense, we're just not going to open up the trial. So all of us are refusing certain clinical trials to participating in because we really don't see much merit in there. So I would say the portfolio already, when patient comes to us, is a pre-selected one. Yeah.
Those are great points. Thank you for bringing them up.
Chris, I think you had your hand up next.
Thank you. I hope y'all can hear me.
We can.
Okay. First of all, thank you all so much for your sharing your expertise and also for the patients for sharing their expertise as well. But I wanted to ask specifically about Cabometyx, and what I wanted to know about it is, how do you kind of determine, you know, I've been on it for a while, how do you determine what's the right dose? You know, balancing side effects, breaks, and all the rest of those kinds of things. How do you figure that out?
Yeah, I'm happy to take this one. I mean, I think it really is, again, it's a partnership with patients. And I think, you know, cabozantinib, most of the time when it's used by itself, is started at 60 milligrams. And that's a dose that most patients are not going to tolerate. You know, 1 out of 3 patients will stay on 60 milligrams, you know, based on the study that led to its approval. Now, cabozantinib is 9 and 99 connected to 242. Okay. Getting wet. You should. So cabozantinib is a unique drug. It has a very long half-life, and so a lot of us play with the schedule. And so, you know, some of us will give it Monday through Friday with weekends off as an initial kind of dose modification. But there's a lot of manipulation you can do based on building in breaks or reducing the dose. And it really just takes like listening to our patients, how they're doing, how their labs are doing, how they're feeling, to figure it out. I mean, I have some extreme examples where I have, you know, some patients on 20 milligrams that take it every other day. And that's all they've needed for a number of years. But that's obviously an extreme scenario where it's worked very well. They've had a hard time tolerating it, and that's what we arrived to. But it took a lot of trial and error to figure that out with them. And sometimes Hans and his group have really recently shown that, you know, sometimes you can re-escalate cabo later and get the cancer back under control. And so sometimes we play around with increasing the dose later if the cancer begins to progress and they're tolerating that new dose. And so it's a unique drug. And that's where I think seeing a specialist that has a lot of experience in kidney cancer and these drugs can be very helpful, because we're used to playing these games with these drugs and working with patients and finding the right dose. There's not a one size fits all.
Thank you very much. One more quick follow-up, because I know there's others that want to talk, but with regards to that medication, you know, trying to strike a balance between being brave, courageous, tough, and stupid, you know, in terms of how much you should take, like how much side, you know, you expect you're going to have some side effects with this stuff. I mean, you know that that's going to happen, but just trying to figure out, my doctor's Dr. Tanier over, I guess works with you over at MD Anderson, but just trying to figure, how to communicate with him, what to say, and how much I should expect I need to take this. I started on 40, now I'm on 60s, and I'm tolerating the 60s okay, but it's not fun. So just trying to figure out, and I'm having good results. So trying to figure out how to strike that balance is the part. And I guess what you're saying is talk to your doctor.
Yeah, well, I'll tell you, Dr. Tanier is the mentor who trained both Pavlos and myself here. So he's a legend and taught me a lot about my management of kidney cancer. But yeah, I think working with your clinical team, if patients are having trouble, I ask patients to send me an update, at times weekly or every other week. How are you doing? And if things are going great, like thumbs up is a quick thumbs up. But if things are struggling, we'd rather know about it earlier as compared to a patient getting like a non-healing wound on their foot that now they have to be off of therapy for months because we didn't act on this earlier. So you can really get yourself into trouble if things get pushed too far.
Yeah, I totally agree. And I would say, a lot of times we start, so especially as patients get more familiar with these drugs, we tend to outsource it to the patient, quite frankly. I mean, you know best when you're in trouble. You know best when you need a break. And you will see that a lot of us are very comfortable with patients making those decisions, right? And then we will see at the scan intervals if the dose intensity was enough or not to keep your cancer under control. And, a lot of patients initially are very motivated to a level that they're hurting them too much, especially when they're for the first time engaging with that class of drug. They typically run into their feet and other complications, etc. But I would say, it takes patience. I think that's the word to use. I totally agree with Dr. Campbell. It just takes some time. I always describe it as like you go in the shower on vacation. You don't get the temperature right the first time. You need to figure it out. And everybody is different. So frequent communication, patience, give your doctor a chance to get it right is important.
I'd like to just make one comment to all of you. It is inspiring to me how you guys know each other's work and what you're working on in different medical centers. I mean, it's just it gives me a lot of hope that there's so much communication between these large centers and that you guys have so much respect for each other to work together in these things. It's awe-inspiring, but that's just an aside. I think Nicole Blackman, you're next up.
Hi, thank you guys so much. It's been very informative and good to see you, Dr. Hammers, again. So one thing that I had a question about was with managing elevated AST and ALT with the liver enzymes. And if you've had patients that maybe immunotherapy has shown to work, but then, we had to take a pause potentially because of getting that in line. And then even like transitioning to a TKI or a second line of Cabo, and also seeing that slight elevation, which can also be, a side effect of the Cabo or other TKI. So just any ideas, in general, with maybe somebody who's like shown good response and is very healthy otherwise, but is struggling with balancing the ALT and AST.
So it depends. It really depends. It's a complicated topic at times, I would say. So, I think if you have, there are many different pictures of these LFT elevations. Certainly, if you're on immunotherapy, you can get someone's very high elevations that can be life-threatening. And if you have a very high-grade effect, especially if it's difficult to control, that's typically an indication where you will not be re-challenged with immunotherapy, at least for a while. It's never. So have I had patients who may have had a very significant autoimmune side effect at some point? For example, I had a patient who was on a combination of, like in the old days, a combination of pazopanib and nivolumab, and I think they added some other drug to it, and he had significant LFT elevations, and he had to come off the therapy, and he eventually progressed. But a couple of years later or so, we challenged him with nivo-ipi, had no liver function test elevation. In fact, he had a nice complete response and is now off therapy altogether. So it depends really on the situation. Some drugs, cabozantinib is notorious for low level, typically LFT elevations, and we don't tend to be worried about it too much. We just observe and see if there's a worrisome trend or not. Sometimes, there's an overhang of immunotherapy into the TKI, meaning, as you know, a single dose of nivolumab, pembrolizumab lasts for a really long time. And so effectively, often you get combination immunotherapy. So you have to be mindful of that. But yeah, it's a complicated story, and, push your doctor for some good explanation of why you're doing what. And don't, sometimes I would say, sometimes, maybe even doctors get nervous if they're not too familiar with cabozantinib with low-grade LFT elevations, and sometimes it can be useful for them to also talk to somebody who uses these drugs frequently.
Okay. Next question is for Paige and Jonathan.
Hello.
Hello.
Hi. Thank you for this. This is very informative. There seem to be a number of people on the CBM 588 probiotic, and we see it. I hear about it a lot with immunotherapies. But what if you're not on an immunotherapy, but you're on like a belzutifan and currently having success with the drug? Is that something that might be worth looking into to see if it helps, or what's your thought on that?
I let Matt take this one.
Sure. So just to rephrase, so you're on belzutifan now, it's working, and the question is, if I add on immunotherapy, will I get additional benefit? Or did I not hear that correctly?
No, the question was the CBM 588 probiotic that you see. So it's kind of like, if it's not broke, don't mess with it. If it's working,
I think the probiotic data is very intriguing, and like our group here has been very interested in that, and we have, especially in our melanoma group, we have a group that have been very interested in trying to fine-tune optimal diet and how that may influence immunotherapy response. And a lot of it is getting naturally occurring probiotics. And so you get probiotics from 4 foods. You can get it from Greek yogurt. You can get it from kombucha. You can get it from kimchi. You can get it from sauerkraut. And then very high fiber diet. And so while, these drugs may not be available, at market, and we don't have a lot of data with how they interact so far with drugs like belzutifan, I encourage a lot of patients to try to follow this diet of very fiber dense, very rich and naturally occurring probiotic foods, and then lower in processed sugar, processed meat as my recommendation when patients are on cancer therapy, as what we know as today is potentially best fits for how they can help modify. I think there's also data, with yoga being beneficial, and I think trying to get good sleep and managing stress. And so there's a lot of little things that can be done. I don't have data that supports, addition of that specific probiotic to belzutifan suggesting it's going to work better. But it's a great question.
Okay. Any further questions? Not seeing a lot of hands, and we're at the allotted 30 minutes, but if there's any other questions, we'd love to get to them. Okay. Well, first of all, I know Dr. Manley has a hard stop here in a minute. I want to thank our panelists. I mean, this information is absolutely wonderful. I love the questions, from the patients and caregivers. We're all in this fight together, and the more knowledge we can have, the more power we all have. Just want to kind of close by saying that this event, our monthly open forums, our podcasts, our upcoming celebration of life dinner are key to our mission of supporting and educating kidney cancer patients. And events such as these are a great opportunity for the medical and pharmaceutical industries to help us reach and educate warriors battling these diseases. We have, and this is a heartfelt plea, we have seen a decrease in funding in the past few years from corporate sources. I would once again like to thank Merck for their support. I would further ask that other pharmaceutical companies attending tonight please advocate within their organizations for further support of ours and other foundations. We're all battling for every fundraising dollar, but I really think these organizations, as well as these doctors who are fighting with us, appreciate the support and want to keep doing what we're doing. I'd also ask our fellow warriors, if you feel this information is valuable, please let us know. We're always trying to push more information out there that is valuable to you. So you can contact Linda through the website. Let us know what you think. Let us know what we can improve on next time. Let us know what you want to hear about, and maybe we can advocate for that. But again, to the panelists, thank you guys for everything you're doing for us. It's inspiring. It gives us so much hope every day. So thank you for everything you do. Is there anyone else who'd like to say anything in closing? Okay. Well,
thank you for having us. It really is an honor, and we all learn together, and very much appreciate the opportunity to spend the evening with everyone.
Same here. Thank you so much, Rich. Great job.
Thank you.
Thank you indeed for having us. It was a pleasure and a privilege.
Well, we'll have to do it again soon. I think, like I said, we all learned a ton. So thank you so much. All right, with that, we'll close it down. This will be available online, I believe. So if you have other people who you feel could benefit from this information, again, please direct them to the Judy Nicholson Kidney Cancer Foundation website. Good night, everyone.
Thank you very much. Thank you.
Thank you.
The Judy Nicholson Kidney Cancer Foundation, dedicated to providing support and education for kidney cancer patients and caregivers.